Good morning. So today we're going to talk about traumatic cardiac arrest. The content of this talk, we're going to revisit the concepts of shock and exsanguination, bleeding mimics, and the physiology of that. And I think it's really important just to kind of cover that again, because it provides context to the different causes of traumatic cardiac arrest and how the management of TCA varies depending on what you think the primary pathology is. We're going to look at the up-to-date guidance for TCA management that's been recently updated by the European Resuscitation Council. There's a few edits that are important just to review there. I'm going to spend a bit of time differentiating between low output state and what I've termed true arrest or actual cardiac arrest, because it's not clear cut. The presence or absence of pulses is not necessarily the onset of traumatic cardiac arrest in some patients. We're going to look at the concept or the topic of chest compressions and when we may want to undertake these and when we might want to omit these depending on the etiology of the TCA. And then I'm going to finish off by talking about resuscitative thoracotomy from an anaesthetic perspective, because there's certain things that we can add to this as anaesthetists with regard to our understanding of physiology and also where we stand physically within the trauma bay when one of these procedures is being undertaken. So to start off with, we're going to come back to this paper which I keep referring to in these talks, and I think it's really important to have a look at this if you have a chance, because it's a really fantastic overview of what the physiology of exsanguination looks like. So just to recap some of those key points, tachycardia doesn't always occur. Blood pressure is a really poor marker of intravascular volume status for a few reasons, and some of this evidence is pretty historic, Second World War era, where they looked at patients who were bleeding to death. Only a third of them became hypotensive and tachycardic, that traditional shock physiology that we're used to or we've been taught to expect in bleeding patients. And actually, they don't look like this. Not an insignificant amount of these patients were actually bradycardic when they were profoundly hypovolemic, and we'll look at why that happens in a few moments. And in healthy subjects, their tachycardia doesn't always even exceed 100 beats per minute, and it makes these patients really difficult to identify. And one of the aspects of the paper that I wanted to touch on was this graph that they presented, where they venesected healthy volunteers. And just to orientate you, the y-axis is lots of different physiological variables, and the x-axis is time in minutes. And you can see that as volume was removed, venous blood was removed, peripheral vascular resistance increased, heart rate increased. Note that it didn't actually exceed 100 at any point for most of these volunteers, and blood pressure remains pretty static because they're compensating. There's a physiological tipping point in some patients, particularly younger patients, whereby you dump your peripheral vascular resistance, you become profoundly bradycardic, and not unsurprisingly, your blood pressure bottoms out. And a number of those patients fainted at that point. And we see this phenomenon in trauma fairly frequently in patients who are very hypovolemic. And it's probably C fiber mediated reflexes in the left ventricular myocardium, whereby it's underfilled, it's working really hard, and the heart goes, no, we need to slow down to allow filling. And in the context of profound hypovolemia, it doesn't work because obviously there's no volume to fill the heart with. But there's some experimental evidence that would suggest that it's actually a protective factor. And if we try and pharmacologically reverse this process, then some of the outcomes in these patients are actually worse. So we refer to this as the biphasic heart rate response, and it's part of the reason why the physiology of bleeding patients doesn't always present with hypotension and tachycardia. And this biphasic response, this bradycardia and peripheral vasodilation that this study has quite clearly demonstrated occurs, seems to be more prevalent in penetrating trauma. And there's something about the tissue injury, the pain and the ischemia associated with that in blunt polytrauma that protects patients from this biphasic response. So we would expect a blunt polytrauma patient to probably have more traditional shock physiology. So let's move on to exsanguination, the process of losing blood to the point of cardiac arrest. It's really difficult to recognise, and it's difficult because the physiology is very variable, and we've just explored that already with looking at that little paper. And now this is a graph from ATLS manual. It would suggest that you can break down shock severity based on physiological variables, but we know that's inaccurate. There's loads of papers out there that show that this is an unpredictable field of medicine, and it's really difficult to recognise some patients who are bleeding to death. Which brings us on to the concept of, well, how on earth are we going to identify these patients? And a lot of pre-hospital services are now thinking about the hateful eight of exsanguination, and I'm trying to validate whether or not this is a better model for recognising those patients who are sick. And it's much softer examination-based clinical signs and symptoms, kind of going back to those core principles of how we assess our patients. So what we're looking for, well, diaphoresis, a lot of patients, and certainly in my experience, patients who are profoundly hypovolemic are really pale, they're really sweaty, the cannulas don't stick, you need to bandage them in place. Venous tone is quite variable. I think in incisional trauma, patients maintain their veins for quite a long period of time, and I've certainly seen patients who have exsanguinated from a brachial artery, for example, and the veins were like drain pipes. And maybe that's because they've got that biphasic autonomic response where they're actually vasodilated at the point at which they decompensated. Whereas in blunt trauma, they tend to be profoundly vasoconstricted and you can't get any peripheral cannulae in. Cerebration, I think, is really valuable. That's a fantastic marker of compensation. As soon as a patient without brain injury, I should state, who's bleeding to death, starts to get a little bit confused. They complain of thirst, they feel sick. Oh God, I feel like I'm dying. You know, those kind of phases like are really warrant or rather predict rapid deterioration. And as soon as there's any confusion, they drop a point in their GCS, that's the point at which they've decompensated, and we must intervene at that point right then. Ignore the non-invasive blood pressure. If they're not perfusing their brain, then they need volume. End-tidal CO2, I've got a whole slide on this because I think this can be really useful in differentiating between brain injury associated cardiac failure and exsanguination. And I will touch on that concept a bit more in a few moments. Air hunger, so patients who are really hypovolemic, metabolically acidotic, it's driving their ventilatory system. But there's also, I think, something about big tidal volumes, big negative interthoracic pressures trying to pull blood back into the right side of the heart that drives some of this air hunger that we see in these patients. Heart rate is very variable. They can be bradycardic, normocardic, tachycardic, so expect the unpredictable. And blood pressure I've put in brackets. So non-invasive blood pressure is a make-believe number in these patients. It will read unreadable, unreadable, normal, high, low. Don't rely on it. It's the last thing that I look at when I'm assessing a patient's cardiovascular status, because I don't want a normal looking blood pressure to bias me into thinking that they're okay. Invasive blood pressure is really valuable, and actually I think we should probably be working towards, as part of our primary survey, getting early femoral arterial access in our patients, our big sick major trauma patients. It gives us a therapeutic option if we think that they need an endovascular resuscitation strategy, but it also gives us reliable hemodynamic data, which will allow us to be a bit braver about which patients we can take through scan if we can concurrently resuscitate them with a Belmont and we know exactly what their blood pressure is doing. And that's something which I think we need to think a little bit more about going forward. Okay, so just a couple of slides on bleeding mimics, and then we're going to move on to the main content of the talk, which is about traumatic cardiac arrest. So there are loads of different conditions that mimic a bleeding trauma patient, and this makes our life really difficult because we already know that the physiology of exsanguination is really variable and difficult to predict. So the first two are prodromal activity and vagal reflexes. So Patients who have been fighting for their lives, running for their lives, terrified that they're dying if they've been assaulted or stabbed, have this kind of catecholamian come down when they're in a safe environment. They look dreadful. They're diaphoretic, they're pale, their blood pressure's all over the place. But actually, with a little bit of analgesia or anxiolysis, maybe a smaller bit of ketamine or a little bit of fentanyl, their physiology normalizes. So we can use analgesia as almost as a diagnostic tool for these patients. The presence of an incisional wound, breaching of the pleura or the peritoneum, or blood present within the thoracic cavity or the abdominal cavity can stimulate or cause profound vagal reflexes, particularly in younger patients. And again, they look really sick. Now, they won't deteriorate to cardiac arrest in this context. They will get better, but sometimes a bit of analgesia just helps to differentiate that patient from a vagal reflex from a profound hypovolemia physiological status. Traumatic brain injury. So this is really important when we come to think about traumatic cardiac arrest. We know that our brain injured patients have heart failure. Some of them have heart failure. I'm going to talk about that in the next slide. And we have to be absolutely certain that this isn't a brain injury related cardiac arrest in blunt polytrauma, because the management priorities are very different to somebody who's hypovolemic. And we'll explore that in a few moments. Cardiac tamponade, tension pneumothorax, it's part of our traumatic cardiac arrest algorithm. If they've got a tamponade, they need a thoracotomy. If they've got a tension pneumothorax, they need a finger thoracostomy followed by an intercostal drain. And cardiogenic shock in polytrauma is way more common than I think we give it credit. And I'm going to talk about why that occurs as well. Okay, so why do brain injured patients become cardiovascularly compromised? Well, any concussive force through the brain, and particularly the brain stem, and note this doesn't have to be associated with abnormalities on CT scan. Okay, this can just be concussive forces through the skull itself. Results in a catecholamian surge. You get profound vasoconstriction. You get all kinds of ventilatory mischief going on. So they breath hold, they become hypercarbic, hypoxic, and you also get catecholamian effects on the heart itself. And the combination of all those factors causes the heart to fail, and they become profoundly cardiovascularly compromised. And they tend to get what we call a Takotsubo-like cardiomyopathy. Now, this echo video on here is what you would see in someone who's got broken heart syndrome, so like a big emotional event, big catecholamian surges, or sympathetic rather activity, should I say, and they get a stunning of the apex and the mid portion of the ventricle. Now, in brain injury, it's the other way around. It's the base of the heart and the mid ventricle that stuns, but the apex still moves. And it happens because of the dump of catecholamians into the circulatory system in combination with the apnea and the hypercarbia that happens because of the ventilatory sequelae of brain injury. The heart fails also because it can be bruised, so steering wheel injuries to the chest. You get valvular disruptions, coronary dissections from blunt trauma. Patients are often cold and acidotic. You can get catecholamian release for other reasons other than just brain injury, and again that damages the myocytes. If you actually have a pathological injury to the brainstem affecting the cardiovascular center or a high cord lesion, then these patients will present cardiovascularly compromised, but may not actually be hypovolemic. And cytokines, so you get cytokine storms in patients who have large body surface area traumatic injuries, so big muscle bulk damage and injury. And again, these cytokines, can damage myocytes and cause endothelial injury and third spacing of fluids. And again, those patients appear cardiovascularly compromised. And the point of this slide really is just to say that cardiogenic shock, so heart failure in blunt polytrauma or incisional trauma, is common, probably more common than we realize. And actually, a lot of our patients may have concurrent hypovolemia and heart failure. And we need to start recognizing those patients. We don't know what the right treatment for them is, though. How are we going to support this cardiovascular system? It doesn't make a lot of sense to support it with more catecholamians when that was the primary cause of why their heart's failing in the first place. And this is an area of ongoing research in trauma. So watch this space, and hopefully we'll have an answer for this in the not too distant future. Okay, so just a slide on end-tidal CO2. I think this is really valuable in being able to differentiate patients who have heart failure from brain injury and those who are cardiovascularly compromised because of hypovolemia. You'll all be familiar with this kind of West zone representation of the lung and VQ matching. So in hypovolemic patients, they will be hypocapnic, either because they're tachypneic, because they're acidotic, or they have West zone 1 physiology because their preload is dreadful. So their right ventricular cardiac output is poor, which means they don't perfuse all of their alveoli, and they have dead space ventilation. So your end-tidal CO2, your measured CO2 expired, will be low. In brain injury, that doesn't happen. So they'll either be normocapnic because they have heart failure, left ventricular failure, back pressure across the lung. It improves the ventilation, or rather the perfusion of the alveoli, because you splint them open because of the back pressure, and you get a more optimal VQ matching. Or they're hypercapnic because they have ventilatory issues secondary to brainstem concussion or injury. The take home is, if you're hypovolemic, expect the end-tidal CO2 to be low. But if you tube these patients and the end-tidal CO2 is high or normal, and your working diagnosis was one of hypovolemia, just have a second thought. Think to yourself, is this patient cardiovascularly compromised because they've got a brain injury, because their CO2 is normal or high? Okay, moving on to traumatic cardiac arrest. So this is the up-to-date algorithm by the European Resuscitation Council. Things to highlight: 2 H's, 2 T's. So it's a little bit more simplified in trauma. We don't have to think of all the reversible causes. We just need to exclude hypoxia, hypovolemia, tension, and tamponade. There's an emphasis on proximal aortic control, either using endovascular techniques such as Reboa, or a resuscitative thoracotomy, which can be left lateral or clamshell, to get control of the aorta. And you might want to do that either to help resuscitate the heart, and we're going to talk later about the concept of aortic arch resuscitation, or you're doing that to get hemorrhage control below the diaphragm, either from a subdiaphragmatic exsanguination or pelvic groin or buttock exsanguination. There's an emphasis on blood and blood products and the use of massive hemorrhage protocols. I mean, that's old news now. We're doing that already at NUH. And when it comes to invasive surgical procedures such as resuscitated thoracotomy, we need to be thinking about futility and whether or not it's the appropriate thing to do. Now, it's given an arbitrary cutoff of 15 minutes, but I've got a slide that's going to talk about why that time frame, it's not as clear cut. It's context specific. And we talk about the 4 E's, whether or not you've got the expertise, equipment, environment to undertake this procedure, and whether or not the elapsed time is appropriate to undertake it. And I'll provide some more information on this in a few moments to clarify that. So let's think about patients who are exsanguinating and deteriorating into traumatic cardiac arrest, and how that physiology may progress. So they'll start off looking a bit shocked, and they might have hypotension and tachycardia, or they might not. And we've spoken about why that physiology can be quite variable, but they probably start to demonstrate the signs and symptoms of the hateful eight, so that diaphoresis, pale skin, poor venous tone, they're starting to become a bit decerebrate, they're not really perfusing their brain very well, etc. He then gets all kinds of variable heart rate responses, and they might vasoconstrict or vasodilate. And at some point during that process, they won't have palpable pulses. But that doesn't mean that they're in cardiac arrest yet. They're probably in a low output state in trauma. And I've seen this on a number of occasions where I've had patients who've been stabbed somewhere in their torso. They don't have palpable pulses, but they're still talking to me. They're a little bit confused, but they're clearly perfusing their brain enough to be awake, but they don't have, to my palpation, a digital palpable central pulse. And it blew my mind the first few times that I saw that was even possible. But the point of that is that it means the onset of traumatic cardiac arrest, the onset of no flow to the brain and to the heart, is very difficult to predict. because, you know, you see these patients and someone goes to feel their central pulse and they can't feel their pulse, but they're still kind of breathing a little bit. Is the onset of rest then? Do we start the clock at that point, or do we start it when someone else can't feel the pulse? So it makes that onset very difficult to predict. At some point, there'll be an tachy-PEA rhythm, and then that will become broad complex, bradycardic and asystolic. And I would suggest that the onset of traumatic cardiac arrest in exsanguination is when they become broad complex and bradycardic, because that's the point at which there is no flow to the brain. I think we should see hypovolemic cardiac arrest as a spectrum of two disorders which have conflicting management priorities. At first, you have a tachycardic PEA low output state. If you were to put an echo on, it would look like this. It's working really hard. Arguably, the heart would be more empty than this. And what we need to do is fill them. We need to give them blood products. And chest compression is probably the wrong thing to do. And I'm going to talk a little bit about some animal work which showed worse outcomes in this context. And it's probably worse than the outcome in that animal model because it's impairing right ventricular filling by doing chest compressions. However, when they become broad complex bradycardic and eventually asystolic, then the myocardium is so metabolically deranged that it's resulting in this kind of bradycardia. And the only way to get a ROSC at this point is to re-establish coronary perfusion. So the priorities are filling, hemorrhage control, and then if the heart doesn't respond, you're going to have to do some chest compressions to get coronary perfusion back online, to then get a ROSC, which will then improve their cardiac output. Before we look at that animal model of chest compression and exsanguination, let's just talk about tamponade quickly, because actually, in someone who's been stabbed in the chest, deciding when to do a thoracotomy isn't straightforward, because on the one hand, you can go, well, hang on, this could be low output state in trauma, exsanguination, they're only just a bit bradycardic, or they've got a tamponade, in which case it's slightly different. So this is some survival data from London, looking at pre-hospital thoracotomies. If you're going to have a tamponade that's survivable, you want a right ventricular wound with a tamponade. You want your thoracotomy pretty much immediately. But what's fascinating is that a significant portion of these patients at the point of cardiac arrest were asystolic. So in exsanguination, asystole is probably a marker of maybe futility, but certainly very, very poor prognosis. But that's not true in tamponade. And it might be that that compression of the heart, the absence of ventricular filling at all, just turns off all the pacemaker cells, and therefore you go from having an output into asystole very quickly. So don't use asystole in the context of tamponade as a marker of prognosis, is what I'm trying to say. Okay, so let's think about timeframes then for wanting to do a thoracotomy, or decision-making points. In exsanguination, you'll have low output state, you'll have no pulses, but the onset of actual no flow to the brain is very difficult to predict because of the reasons we've discussed. So I would suggest the onset of cardiac arrest is when the patient becomes bradycardic, whereas in tamponade, the onset of cardiac arrest is when they lose consciousness, because they lose consciousness and they decline into asystole very quickly. So if you're trying to make a decision about when to do a thoracotomy in a patient who's been stabbed, I would suggest that if they have any complexes on their ECG, they're potentially viable, or they're within 15 minutes. And they only have to have one or the other, because you don't know whether or not it's exsanguination or tamponade until you open the chest. Let's talk about chest compressions. So we're going to look at some exsanguination models in exsanguination animal models about when we should or shouldn't do chest compressions. And this GIF here is a patient who's in cardiac arrest. They've got a TOE probe down and they're having external cardiac massage, so external chest compressions. And you'll see that actually all that's really happening is it's compressing the right ventricle. The left ventricle is not moving really at all. And you probably haven't got very good forward flow through the aortic valve. So we know that external massage isn't that efficient. We need to think about bleeding mimics though, because if we say, well, this patient's in traumatic cardiac arrest and we shouldn't do chest compressions at all, what about the patient who's got a brain injury and has got a failing heart from brain injury? we should probably be managing those patients more like a medical cardiac arrest. You know, they need adrenaline, they need chest compressions, they need filling. And that's why your primary survey, your examination of these patients is so important, because the findings of that primary survey will help you determine the etiology of that traumatic cardiac arrest. And just having a set algorithm for all TCAs is probably the wrong approach. I've got a couple of slides at the end just to look at this concept of aortic root resuscitation and the role of biochemical management in these kind of patients as well, but we'll touch on that a bit. Okay, so this paper was really interesting, done in Portland Down, looking at porcine models of exsanguination and the role of chest compressions, and it was published, not exactly sure, 2019, so a couple of years ago. The outcome of the study, so they had quite a complex model of exsanguination in terms of what they did, but there were 5 groups. Either they got chest compressions and nothing else, they got blood product resuscitation, so whole bloods, they got saline resuscitation, and then they had whole blood with chest compressions and saline with chest compressions. And you can see that the whole blood group without chest compressions probably did the best, followed by the saline group. And as soon as you started adding in chest compressions, then it was kind of impacting on the overall survival of these porcine experimental models. Another way of looking at the data, well, this is group 1 and group 2 and 3. So if you look at whole bloods, you had a better ROSC than you do with saline. As soon as you added in chest compressions into the saline group, more of them died. The whole blood group was a little bit more complicated because there were 2 different endpoints to the study, but the take home really is that whole blood without chest compressions is probably better. Now, it's not quite as straightforward as this though, because remember what I was saying earlier, that chest compressions may still be needed in patients who haven't got a pure exsanguination model. So think back to your primary survey, examine your patients, think about the mechanism of injury, and try and pick out those patients who may benefit or won't benefit from chest compressions. And take that one step further as well. Let's say this is incisional trauma. You think this is pure exsanguination. That patient has declined into traumatic cardiac arrest. They've got a broad complex bradycardia or asystole. You've got hemorrhage control. You've filled them with blood products and the heart hasn't responded. Well, that heart does need chest compressions for you to reinstitute coronary flow. That's the only way you're going to get a ROSC. Compare that to the same patient, the same mechanism of injury, who's got a tachycardic PEA. Well, that patient doesn't need chest compressions because you're probably going to impair right ventricular filling. They just need volume resuscitation. And you can see how actually, you know, the management of traumatic cardiac arrest is very nuanced. It's dependent on anatomy of injury and physiology. Okay, coronary perfusion. So let's just focus on this for a little bit. The name of the game in traumatic cardiac arrest is re-establishing coronary perfusion. That's the only way you're going to get a ROSC. And we can do this in a number of ways. So we need to think about aortic root pressure. How are we going to get the aortic root pressure up and quickly so we can perfuse the coronaries? Well, we might need to think about endovascular resuscitation, so putting up a balloon in the aorta, or a thoracotomy to squeeze that descending thoracic aorta to get the root pressure up quickly. But you've got to pick the right patients. You've got to think about futility, associated injuries, and whether or not that's what they need from a physiological perspective. Because a patient who's in tachycardic PEA probably doesn't need that. They just need volume. We need to think about whether or not we need to do cardiac massage. So those broad complex bradycardic or asystolic patients who you've volume resuscitated in exsanguination need chest compressions. And those bleeding mimics, such as the brain injured patient who has a failing heart, need chest compressions. And they may also need a little bit of adrenaline just to get things going again. Bicarbonate, possibly to reverse the metabolic acidotic picture, which is impacting on their cardiac contractility. There's a lot of controversy around that. We're never going to be able to do a study to look at the value of that, but it might be worth considering. And they almost certainly need calcium. Your serum calcium levels fall pretty quickly just from trauma itself, but also blood volume resuscitation. We need to be getting calcium in early if we want that ROSC to occur and to be sustained. Okay, last slide about thoracotomies. As anaesthetists, we may be present when a resuscitative thoracotomy is being undertaken in ED, and there's a few things that we can help with, I guess, because we're in a unique position where we can maintain really good situational awareness. We've got a tube down, we're ventilating the patient, and we can be there to support our surgical colleagues who are going to be really task focused on doing something which they're trying to save the patient's life, and it can sap your bandwidth a little bit with regards to that. So what's going to happen with thoracotomy? Well, we should always open a pericardium. Okay, you need to assess for a tamponade. It will allow you to do effective internal cardiac massage, and if there's a wound to the heart, then that can be closed. We need to think about hemorrhage control. So there's no point filling the patient until you've sealed the arterial system. So be it a wound on the heart, the lung, major vessel, intercostal space, whatever the bleeding source is, we need to get closure of that quickly. And once that's been achieved, aggressively fill the patient to get that aortic root pressure up again. In terms of how to get hemorrhage control, do as much as needed, but as little as possible, to try and keep it simple. We can do that with sutures, staples, catheter ligations if we're thinking about getting hylar control from a shredded lung that's exsanguinating. Atraumatic clamps can be really helpful, particularly for right-sided cardiac lesions. And remember, this is all damage control. This is just what you're going to do in ED. And as soon as a major trauma surgeon is present to be able to do more definitive closure and a much cleverer surgical wizardry, then that's fantastic. But this is, just getting immediate hemorrhage control in ED so you can fill the patient. We need to think about early aortic compression whilst we're concurrently filling the patient to get that aortic root pressure up, which will encourage an earlier ROSC. And internal cardiac massage, and this is really where I think as anaesthetists we can really help. The internal cardiac massage has to be dynamic to the physiology of the patient. What do I mean by that? Well, you've got to keep the heart horizontal, and your rate of massage is proportional to the volume status of the patient. So if the heart is completely empty, there's no point doing any cardiac massage. You're just going to bruise the myocardium. Now, as the heart starts to fill, you'll feel turbulent flow between your fingers as the ventricle's filling, and your massage will be at the rate at which the heart fills. So an exsanguinated patient, you might start at a rate of 20, 30, and you're slowly going to build up as filling status improves. And you need to think about what you're trying to achieve. So start at the apex and compress towards the base of the heart so that you're encouraging the aortic valve to open, forward blood flow out through the aortic valve and down the coronaries themselves. And a combination of that with aortic compression, blood product resuscitation, and oxygenation through a definitive airway is how you'll get a ROSC in these patients. Thank you very much. This is the reference list. Thanks for listening, and I will open up for questions now.